Chapter 17, we're going to talk neurologic emergencies. This is going to cover things like stroke, seizure. We'll talk about syncope, altered mental status, just as sort of a whole blanket term. And that'll lead us into our lectures on endocrine emergencies and on behavioral and psychiatric emergencies. What we're going to see and figure out today is there is so much stuff that can cause altered mental status. It's a lot of times difficult to figure out, is this true altered mental status? Is this behavioral? Is this psych? Is there some thing that I can find and put my finger on that is causing this patient to be altered? And if there is, can I fix it? That's why since the beginning, I've always advocated if your patient is altered in any form or fashion, we're going to add something to our vital signs. We're always going to take a blood sugar, because since there are so many causes of altered mental status, do the easy things that help you figure out, is this the problem? Is this not the problem? We can take a blood sugar and find out in the blink of an eye, is hypoglycemia, is low blood sugar what is going to cause this patient to be altered, to be having this neurologic emergency? The same will go when we talk about stroke scale and completing that on someone who's got an altered level of consciousness or an altered ability to be oriented and have a conversation with us. If we start checking off the boxes, it's a whole lot easier when we get to the end and we can say, all right, well, we did this evaluation and it wasn't this. We did that evaluation and it wasn't that. There's no signs or symptoms of this. So I can start, whittling my list down to what's going on with the patient. Because how often do you think we get sent out for, behavioral emergencies, chapter 22, which is the last little bit we'll talk about today, or the EDP, right? The emotionally disturbed person. That is a huge contributor to our call volume, because there is a mental health problem worldwide right now. Okay, that's fine. I can make my peace with that. But if you go into that emotionally disturbed person, just looking at it as, all right, another crazy, it's very, very possible to miss some of the more subtle things, where if we went into it with that sort of open mind, all right, EDP to me means altered mental status. I'm going to go into my assessment of that patient thinking altered mental status and trying to build my case around what could be wrong with this person. I have a very low threshold for this altered mental status could be the result of a medical problem, an issue that I can work to correct, versus just going in and being like, yeah, they're crazy. They're just drunk. They're just this. Because a lot of the times those types of things can be masked or work to mask by altered mental status. And going into it with a clear view of your patient and doing all the steps of our assessment, even if it does just seem like we're getting to the point where this is a behavioral, this is a psych, this is drugs, this is alcohol, making sure that we don't miss the forest through the trees and kind of miss an opportunity to provide maybe appropriate medical care for our patient who may be drunk and may be high, but may also have a low blood sugar, may also have some hypoxia, may also have some signs and symptoms of recently having had a seizure or a head injury. And we don't always necessarily get that when we go into the call thinking, yeah, all right, altered mental status, sure. We got sent out for an EDP, and this patient's just crazy, or this patient is just using. We have to make sure we do our due diligence and run everything to ground before we just come to the fact that, yes, their neurologic problem is just they're nuts. First thing we're going to talk about today is stroke. And stroke is one of the more nefarious things we can see in the field. This is one of the bigger problems that we'll see in our elderly population. We're actually starting to see patients younger and younger and younger starting to have strokes and transient ischemic attacks, which is sort of a precursor to stroke we'll talk about. But it's the fifth leading cause of death, and it is the leading cause of disability in the United States. So not only does it kill a lot of people, the people that stroke doesn't actually kill. It turns their life upside down and limits their ability to be a productive member of society for the rest of their existence, just because of what it does and how it works. And those are some of the things we'll talk about today. We'll get into all the contributing factors for stroke. We'll talk about some treatments. We'll talk about some of the new treatments that they've come up with that are actually helping to reverse some of the disability. So we're actually widening out the window as to when strokes can be treated. Because at the end of the day, when they reperfuse tissue, so they go in and they break up that blood clot in the cerebral artery that's causing that stroke, and they supply oxygenated blood back to that brain tissue, they've learned through time and trials that there's really no specific time frame as to how long a piece of healthy tissue can go without receiving that oxygenated blood flow to where it's either ischemic or infarcted. Because if it's still just ischemic, reperfusion is going to work. If it's infarcted and dead, reperfusion is going to have absolutely no benefit whatsoever. And the last little bit we'll talk about is seizures and sort of other common causes of our neurologic emergencies. And that's where we'll get into just sort of altered mental status a little bit. First thing we have to get into is speaking about some anatomy and physiology as per usual. We know that the brain is the body's computer. The body's response to what the brain tells it is carried along those neural pathways. The brain is in control of everything that the body does. It controls breathing, it controls respiratory rate, rhythm, and quality. It controls speech and any other body function that you can come up with. The major parts of the brain are the brain stem, the cerebellum, and the cerebrum. The cerebrum is the biggest part of the brain tissue itself. It's most of that actual organ is the cerebrum. The cerebellum and the brainstem are both really sort of small pieces of this whole organ, but arguably they are some of the more important because the brainstem controls most of our basic functions. The brainstem is really what is running the show when we talk about heart rate, respiratory rate. The cerebellum controls a lot more of our more voluntary things. So our brainstem is really our connection to life. When the brainstem becomes damaged or the brainstem has any sort of problem, all of the basic sort of involuntary things that our body does are going to suffer. When the cerebellum has an issue, we'll say a stroke, whatever the case may be, head injury, doesn't really matter altogether that much right now. But we're going to start to see some poor muscle control and loss of coordination. We know that messages sent by the brain travel along these nerve pathways. It's sort of like the electrical current just passes from our brain down through the neural pathways out to wherever it is that that message was being sent to make that piece of the body do something. We have the brain and the spinal cord as our central nervous system. That central nervous system is pretty much the highway that all these messages travel upon. So the brain sends out a message, it gets carried through the central nervous system, down through the spinal cord, and we get to these spinal nerves, and those spinal nerves are where things begin to exit. So those spinal nerves are going to be what conduct all of these impulses out to the rest of the body. So you see there in the middle of our picture, we have the brain and the spinal cord. Those is going to be our central nervous system. And then when those nerves exit out from the central nervous system, we start into the peripheral nervous system, getting down more towards the business end. Those nerves are getting carried out to specific areas of the body, and it's going to get down to make me pick up my coffee cup, or make me pick up my cell phone, or make me click to the next slide. So just about anything can affect the brain's ability to do its job. Think of some of the things that we've talked about already in the realm of our medical assessment and some of the chapters we've covered so far, and think about how all of those things sort of loop back to your primary assessment and your assessment of your patient's level of consciousness. And any of the things that we've gotten into that can affect my patient's level of consciousness are having some form or action on the brain that is making it more difficult for the brain to do its job. Just about anything we can expect to affect our patient's level of consciousness, whether it's, true altered mental status, your patient who's hard to wake up, so they don't do so hot on our AVPU scale. Speech and inability to voluntarily control muscles is also really sort of an altered level of consciousness. If your patient is having a difficult time communicating with you, so that dysphagia, well, clearly the brain isn't really getting all of the function done. Speech is generally something that is very simple, very easy for most people who talk and speak the language. So if you start to notice some little, maybe, just tiny changes in your patient's speech pattern, or difficulty finding words, or you have a patient who is having difficulty, holding on to a glass. Let's say you handed them a pen so that they could sign your run sheet, or, even just the little things start to now point me towards what is going on neurologically with this patient, because clearly the brain's messages aren't being either sent appropriately or received appropriately if your patient has an inability to do the simple things. Now, we have talked at length about the brain being sort of a sensitive sort and needing to have a constant supply of sugar and oxygen. The brain is not going to switch to that anaerobic metabolism. The brain is not going to be able to continue to function without an appropriate supply of oxygen and glucose. The body knows this, and the body works really hard in emergency situations to try and make sure that the brain is receiving that adequate supply. Because if the brain function is affected, what's that going to do to the rest of everything else that's going on? If the brain sends all the messages to everywhere and the brain function is starting to not work so hot, what's going to happen?
Deteriorated mental state.
Deteriorated mental status for sure. But remember, the brain controls everything. So if the brain is malfunctioning, sooner rather than later, everything else is going to start to show and have some sort of malfunction as well. That's why when we really take the grand look at neurology and speech and voluntary muscle control, it goes a whole lot deeper than, is my patient awake? Does my patient only respond to verbal stimuli? Does my patient only respond to painful stimuli? Is my patient unresponsive? Because all that tells me is the basic function of the brain still functional? That's why we get into those conscious, alert, and oriented questions, because at the end of the line, my patient should still know who they are. They should still know where they are. They should still know roundabout what day or time it is. And they should still know pretty closely, be able to tell me what's going on. The worse my patient does on that, I know the less oriented they are, and alterations to AVPU or my patient's orientation level is an altered level of consciousness. It is an altered mental status. And really, we have to chase the cause of this neurologic problem right to the very end, just to make sure that we are appropriately taken care of and treating for whatever that neurological problem might be, or maybe finding the fact that they're having a stroke, because they don't all present in the same way. You may have caught this stroke early because somebody who knows this patient said, I was talking with my mom earlier today, and I don't know, she wasn't as sharp as usual. She was having a difficult time sort of holding down her end of the conversation. Does that immediately, start to trigger your spidey sense and all right, well, that sounds a little less altered than most altered mental status, doesn't it? Maybe it was just early and mom hadn't had her first cup of coffee. But then the more you poke and the more you prod and the more questions that you ask and the little bit deeper into your interaction with the patient you get, you start to circle back to that. Because maybe you do your OPQRST and your sample once you've finished your primary assessment and all that, and you go back and start asking these questions or talking with this patient some more, and then you notice just a little tick in the way that they were speaking to you, or just a little delay in them being able to answer your questions. Is that clinically significant?
Yes.
Yeah, because it shows just another little stitch of deterioration in that patient's mental status. When we talk about mental status, and especially when we talk about shock, and now that we're going to be talking about actual neurological function of the brain, it doesn't have to be this huge, like all-encompassing shift in the way your patient does something, or in the way your patient speaks, or in the way your patient processes something. Even just a tiny delay or change when you're doing your reassessment can start now pushing you towards the idea that, hey, there's something going on here. We don't always have to have our finger on what exactly it is that's going on, but noticing those kind of subtle changes and doing our reassessment and actually getting to the bottom line is going to be really what is best for us. Because if we notice in just 5 minutes that my patient's mental status, yes, it has changed from when I got here, what do you think is going to happen in the next 5 minutes?
Definitely going to get worse.
And it's going to continue to get worse. So what could happen when we get to the emergency room? We're not going to walk through the doors of the emergency room, right? And it's all of a sudden, and everything gets better. The patient's going to continue to deteriorate. So you may be the only medical provider that actually gets all the answers to all the questions directly from the patient's mouth. So now let's talk headache. Headache is one of those things, right? Anybody who's ever had a migraine or a tension headache or anything like that knows that this can be absolutely altering to your ability to be a human for at least 24 hours or more. It's a really common complaint. And when we evaluate a patient who had a headache that was significant enough for them to call 911, we need to actually take this into account that it can be a symptom of something else. Sometimes our patients who are having a stroke will complain of the most ridiculous, severe headache that there ever was that came on out of nowhere, like someone threw a light switch and all of a sudden, wow, terrible headache. That being said, Not all headaches are strokes or brain tumors or aneurysms or these really big, ugly, nasty things that we think about when my patient tells me that their symptom is a really gnarly headache. But since we do have that small percentage, that, 1 out of 10 possibility that this could be something particularly negative for this patient, we have to sort of do what we do and figure out that, okay, their blood pressure is normal, their heart rate is normal, their respiratory rate is normal. They are not failing my fast stroke assessment. They have perfect balance. They have no dysfunction in their eyes. When they smile, their face goes up. When they frown, their face goes down. They don't have that arm drift that we're going to talk about in a few minutes. Their speech is not garbled. It is normal. And they've really just had singular complaint of a headache, and nothing they do makes it go away. Okay, well, I've covered all my bases at that point. I'll probably take a blood sugar. Why not? Can't hurt, might help. I know when my blood sugar is messed up, my head is throbbing. So we check a patient's blood sugar. At this point, we've evaluated them for a stroke. We've evaluated them for hypo or hyperglycemia. We've evaluated for respiratory rate, rhythm, and quality. We've evaluated their heart rate, rhythm, and quality. We have pretty much gotten to the end of the line of things that can be figured out for this patient whose complaint is a headache. Without imaging, there's not a whole bunch more we can do. Maybe they're dehydrated. Maybe they have outside stressors in their life that's causing them one of these. Tension headaches are generally brought on by stress. They're caused by muscle contractions in the head and neck. Pain is normally like a dull squeezing kind of ache, so that's going to be our quality of pain. More often than not, our patient's not going to call 911 for this. These are normally self-limiting. Stress goes away, tension headache gets better. Migraines, on the other hand, can be direct result of changes in blood vessel size in the base of the brain. They can cause all sorts of neurological problems. They'll cause vision issues. They'll cause nausea, vomiting. It's normally described as sort of like a throbbing, pounding pain, like there's a jackhammer inside your head. Can last for several hours, several days. And if we look at some of the signs and symptoms here, nausea, vomiting, and visual changes. Why would I point those things out? Why would those maybe start to make me a little itchy as a provider?
Also symptoms that are related to a heart attack.
So yeah, we could be dealing with some cardiac compromise here. And this visual changes is a big one. Some of the things that we've added to our stroke scale over the year, because it used to just be fast, right? We were looking at face, arms, speech, and time. We want to know time last known well. But we've added 2 letters to that now. Now, instead of just fast, we want to be fast, because I'm looking at my patient's balance, their ability to keep themselves upright. And the other thing that I'm going to look at is any changes with their vision, any changes with their eyes. So when I shine my pen light, does one pupil not sort of respond the way that I would expect it to, maybe? And visual disturbances now are part of our stroke scale. And if they flunk any one of that be fast assessment, they're likely to be having a stroke. The more of that assessment that they flunk, the more the likelihood of them having a stroke increases. So my patient who's having a history of migraines and complained of this headache and nothing they do makes it go away, and they're complaining of some visual changes, what am I best chalking this up to? Just another migraine? or
Possible seizure.
I should be aware of and waiting for them to maybe have a seizure, because if this is a stroke and certain signs and symptoms with a terrible headache and stroke are like just negative things that feed one another. But if I'm seeing signs and symptoms of a stroke, I can't say that it's not. So I should probably be leaning towards it is, because I just found something in my assessment of this patient that says, hey, this patient could be having a stroke. So we'll skip sinus pressure. One of the big things that I've learned over the years, and I learned this from a doc that I used to work with in the jail, believe it or not, was if your patient has a sinus infection or really, really terribly increased sinus pressure that's giving them a headache, ask them if their teeth hurt when they walk, or if their teeth hurt when you push on their sinuses. So when we do our focused exam and you push on where the sinus cavities are, doesn't make their teeth hurt. Because generally speaking, that's a pretty good indication that there's a lot of pressure built up in those sinuses. And if they say no when you do that test, keep doing your assessment. Look somewhere else. Don't just chalk it up to, well, it's allergies. They got a sinus infection. Some things that should really make us start to think if my patient's complaint is headache are listed here on the screen. So headache can just be sign or symptom. We'll go with symptom because I can't really see a headache unless my patient's sort of positioning points me towards, boy, they must be having a raging headache. Some symptoms that headache goes along with the condition are hemorrhagic stroke, a brain tumor, and meningitis. All three of those things will kill someone. So if we see any of these red flags to go along with the symptom of headache, we really ought to be taking a much closer look at this headache in general. So we have sudden onset of symptoms. Your patient, when you get to the O in OPQRST, is going to tell you that it was just not there 1 minute and like a tidal wave the next of just unbearable headache. That's that explosive thunderclap of pain. Any headache that comes along with alteration to their mental status is going to be significant. If my patient has a headache, okay, they have a headache. If that headache is actually altering their level of consciousness, well, there's something to be concerned with there.
Tommy, would a brain aneurysm also kind of fall into some of these symptoms?
Yeah, well, a brain aneurysm sooner rather than later is going to cause that hemorrhagic stroke. Yesterday when we
witnessed a lady, I used to do security in the Seaport Hotel, and I actually witnessed a lady who worked in there. She was complaining about a headache, and then we got up there to try to help her or whatever. And she was Chinese, so she didn't speak English, and she was just grabbing her head and kind of making a lot of noises. And then the EMTs got there, she puked, and then by the time they pretty much got her on the stretcher, she was kind of just quiet. So at the time, I was young, I was just looking at it, didn't really know what was going on, but thinking about it now, in a matter of minutes, she literally went from pretty much screaming and holding her head and then vomited and then pretty much went quiet, and then she ended up dying a couple days later, we heard.
Yeah, the vomiting that goes along with insult to the brain is a scary thing, because that just means the brain is under so much duress that it can't even control the easy things anymore. So vomiting that goes along with a head injury, vomiting that comes along with a stroke, vomiting that comes along with a brain aneurysm that causes our hemorrhagic stroke, that's one of those things where you're just like, oh, this is not good. But yeah, you probably watched it happen and wouldn't even really have any reason to know. How come you think age over the over 50 years is on this list?
Take a shot saying that, I don't know, over the years, your body just kind of depletes over time, and maybe for whatever reason around age 50, things like this are more likely to happen.
You got it. Remember yesterday when we were talking atherosclerosis and arteriosclerosis and all that, and the normal product of aging is these arteries are going to lose their elasticity a little bit. They're not going to be as good at expansion and contraction, and they're going to harden and get more stiff. When they do that, it's generally when we start getting into the later years in life, and our patients over the age of 50 are going to be where we draw the line there. We start to expect to see some changes to their vascular structure, which make them a little bit more susceptible to rupture and showing us things like hemorrhagic stroke or bursting of a brain aneurysm on one of those cerebral arteries, causing significant problems for this patient. That's why when we talk epinephrine, does anybody remember what the age cutoff for just giving an EpiPen is?
No less than 6 months and no older than 60.
65, but close enough.
65.
And the reasoning behind that is the exact same thing. There's changes to the vascular structure over time. And if we are going to give a medicine that is going to greatly affect that vascular structure and increase pressure at the same time, we need to be careful, because what we're thinking at that moment in time is this going to compromise their cardiac system, or is this going to compromise the vasculature in their brain to the point where the epi that we gave them now instead kills them? If we're seeing headache from someone who's got a depressed immune system and is at high risk for infection, we start to think about things like possibly meningitis or other infections of the brain itself. Any headache that comes along with neurologic deficits. So that's still that problem with balance, with eyes, with movement, of any portion of them. That's a neurological deficit. That is, the brain is no longer speaking with and communicating back from that point of the person. So this headache is likely to have something to do with it. Stiffness of the neck or neck pain and fever, they're going to also point us towards meningitis. Meningitis is really treatable when it's bacterial meningitis. They give you a course of Cipro for antibiotics, and it is better in no time flat. Meningitis, when it's viral, viruses just run their course. So viral meningitis is much more difficult to treat. Viral meningitis is sort of much more negative for our patient. And when our patients get meningitis, that stiff neck and fever is like the hallmark sign of it. And really, meningitis is something that can honestly take a patient who was fine 1 minute and near dead the next, because it's just such an insult to the brain. Changes in vision we already discussed, and one-sided paralysis or weakness. Now, I've had headaches before, but I have never had a headache that was so bad that I was blind in one eye or couldn't move one side of my body. These are some of the, like, hey, I'm a stroke waving back at you when you see some of these problems. And then you start adding in, well, my patient's 72 years old. He's having a difficult time seeing out of that one eye. He really can't move that left arm so good. 2 + 2 is 4. We start thinking patient's having a stroke. We need to get them to definitive care. The best thing about the area we live in right now is I was not able to find a hospital in the entirety of the state of Massachusetts that can't begin the imaging and initial treatments for a patient who's having a stroke. So we can bring stroke patients anywhere, and they can start making this patient better. You can bring them to the Everett, you can bring them to the Mass General, and the beginning portions of this assessment and treatment are going to be the exact same. Stroke used to be called a cerebrovascular accident, or CVA. It is interruption to the blood flow in any area of the brain, and that interruption is going to result in loss of brain function. This is still just a perfusion problem. If I have a clot that is clogging an artery in my heart, I have a myocardial infarction or a heart attack. If I have a clot that is blocking off an artery in my brain, in one of the cerebral arteries, I have what the American Heart Association used to call a brain attack or a stroke. Ischemic strokes, thankfully, are the most common. Ischemic strokes happen to 80% of our stroke patients. It's normally the result of a thrombus or an embolus blocking off one of those arteries, and we may have next to no real symptoms or a complete and total train wreck. It is, a little from column A, a little from column B. That atherosclerosis we talked about yesterday is very often linked to the cause of our patient who has a stroke. So atherosclerosis and arterial sclerosis aren't just bad for your heart. That buildup of plaque and that hardening of the arteries as you age is also going to cause your patient to be more susceptible to a stroke. When we look at our ischemic stroke, it has a lot of the same pathophysiology as our ischemia or our infarction to the heart. We have a blockage right here. There's our blood clot. And if I have a blockage right here, tell me what happens to all of this brain tissue that's supposed to be fed by that artery.
Not
It's
getting
gonna
oxygen.
die off.
It's gonna
It's
die.
not getting any oxygen. So it's going to begin to become ischemic. And when it begins to become ischemic, we're going to have some, generally speaking, some alterations to my patient's brain function. Whether it is wholesale neurological problems, they flunk the AVPU, they flunk the conscious, alert, and oriented questions, they don't get any of our stroke scale right. Or maybe it's just something little, and my patient is having a hard time with finding their words, or just is slow to respond to the questions that I ask them. Thankfully, this is 80% of our strokes, because an ischemic stroke is very treatable. It's almost, at this point, sort of reversible. It doesn't cause a lot of the same death and disability that our hemorrhagic strokes are going to cause, and that's what we talk about in just a minute. Because with our ischemic strokes, they can give our patient medicine to go in and dissolve this blood clot. So we'll get them to the emergency room, they'll take some images. After they take those images, they'll decide whether it's an ischemic stroke or a hemorrhagic stroke. If it's an ischemic stroke, they'll give them TPA. TPA is a clot-busting medication that will go up there and dissolve that blood clot. And once that blood clot is dissolved, perfusion is restored. One of the newer treatments they have for stroke, and something that they're using a lot more and has allowed us to now help patients who are having strokes for a longer period of time, is almost like when they go in and do a cardiac catheterization and they clean out those coronary arteries and put a stent in to make them stay open. They're actually doing the same thing in the brain. They're fishing a wire up into that cerebral artery. They're going in and sort of breaking up that clot and vacuuming out the pieces. And then they put a stent in to hold that cerebral artery open. And they are reperfusing the brain tissue at that point. And if we reperfuse brain tissue when it's only ischemic, not when it's infarcted, our patient generally does very well and generally will improve, if not completely resolve, their stroke symptoms. So we'll see somebody, you know, after some rehab who is able to go on and live a very, very normal life, is able to really sort of still do and be the same person that they were before. Now we're going to talk about the wicked stepsister here. Hemorrhagic strokes are only about 13% of our typical stroke patients, but they are more often fatal. So our ischemic stroke patient is much more likely to survive. Our hemorrhagic stroke patient is much more likely to pass away. Why do you think that is? What's the difference? What's going on here?
You have an active bleed inside the head. You're gonna
Yeah, so
put
what's,
pressure against the brain.
yep, keep going.
Blood loss. Now you're getting a blood loss and creating that pressure in the head.
So the brain's being squished, right? That increased intracranial pressure is just squeezing the brain. That's why that thunderclap of headache is our hallmark sign for a patient who's having one of these. Our ischemic stroke a lot of the times doesn't come with really any headache at all. We'll see increased blood pressures with these patients. We'll hear them talking about the worst headache of their life, because when that aneurysm lets go and causes our hemorrhagic stroke, it is an immediate burst of pain. And why do you think these are a little bit more difficult to treat?
Because it's burst open and actively bleeding. So if, unlike the other one, you know, they can add something in to break the clot up. This is an active bleed, so for them to get to it, it's not as easy as the other way.
Right. I mean, Mike, since you're answering the question, we can loop this right back to sort of simple plumbing, right? If you have just a small blockage in a pipe, it's probably a whole lot easier to fix than when a whole piece of pipe is blown out, right?
Yeah, looking at it that way, yeah. You can, you know, if you got a drainage clog, you just send a snake down there to clear it out. But if it's an actual break, you've got to chip up all the concrete, and you got to locate the pipe first, then chip it all up and dig and get to it and then make the repair.
Funny how that worked out, isn't it? So we've covered stroke. We'll get into signs and symptoms here in just a few minutes, but we have to touch here on transient ischemic attack. So when stroke-like symptoms appear and then go away on their own, no intervention, within 24 hours, we call it a transient ischemic attack, a TIA. Generally, it's a warning sign that a bigger stroke is on the horizon. A lot of people, so they say about 1/3, that to me is a lot. 1/3 of people who have a TIA will experience a stroke shortly thereafter. The important take-home bit for us is any patient who has signs and symptoms of a stroke, because TIA and stroke are mimics of each other. They look and present exactly the same. They need to be evaluated. Patients love to be able to talk themselves out of stuff. Oh no, I'm getting better. Oh no, it's not that bad. Oh, this happens once in a while. It's like, all right, fine, this happens once in a while, but let me explain to you that people that this happens to once in a while generally go on to have the big one, and maybe we can avoid that with you. TIA should be evaluated because we're not going to spend 24 hours sitting in this patient's living room waiting to see if their stroke symptoms improve. When we look and evaluate for a stroke, we are looking for facial droop or facial paralysis, sudden numbness of weakness on one side of the body, decreased or absent movement or sensation or poor muscle control and balance, generally with one side of the body. Sudden changes to their vision. Doesn't have to be lost, doesn't have to be blurred, doesn't have to be double, just sudden onset of difficulty with their vision. And it's generally only in one eye. Why do you think a lot of these, what look to be sort of neuromuscular control signs and symptoms, are limited to one side of the body versus the other?
Whatever hemisphere of the brain that this is happening in.
Yeah, the left side of the brain controls the right side of the body. So if we're having a stroke on the left side, generally we're going to see some muscular problems and some movement issues on the right side. If the right side of our brain is having a stroke, we're likely to see problems on the left side because they work opposite one another until we get to the eyes. Generally speaking, the nerves and muscles that control the eye are wired directly to the brain of the hemisphere of that side of the eye. So with a left-sided stroke, we're generally to see right-sided muscular problems, but left-sided eye problems. So that tells me that it's the left side of the brain. The right side, we'll see problems with the right eye and the left side of the body. Did everybody get that?
Yep.
Some other signs and symptoms of a stroke. Dysphagia with a G instead of an S, difficulty swallowing. Decreased level of consciousness, decreased level of responsiveness. Dysphasia with an S. Isn't medical terminology wonderful? Speech problems. Difficulty speaking words or inability to use the right words. One of the things that a stroke patient a lot of the times will have happen to them is you'll ask them a question, right? And they will go to answer that question, but the words that actually leave them are completely wrong. And especially if we're early in the stroke game, the patient will actually hear those words, know that they're wrong, and you'll see them visibly get upset about it. That's because they know in their brain that those weren't the words that they said, but that's the words that left their mouth anyway. And you can actually see that, like that thought happen inside of them. Slurred speech or sudden and severe headache, also going to be on our list of signs and symptoms. Moving right along, we have confusion, dizziness, weakness, combativeness, restlessness, tongue deviation to one side or the other, or they may lapse into unresponsiveness completely, and we call that coma. So if we go back a couple of slides, that is a whole lot of stuff, isn't it?
Yeah.
And we can catch most of those things with what I'm going to put on the screen here next. First, I got to get rid of that arrow so I can actually click on the screen. There we go. So that is video made for your average layperson. And the reason I know that is because the T in Be Fast for regular folks means time to call 911. We are 911. So the T to us is going to be time last known well. Why do you think I want to know, and I really want a very, very clear understanding of the last time somebody saw this patient acting like themselves?
You can find out how long the person has been possibly having a stroke and all these
Yeah,
symptoms.
time last known well is going to tell me how long has this been going on for? How ischemic is that tissue? How damaged is that tissue? How much brain has been affected? How much blood has leaked in if it's a hemorrhage? So it's going to give me a pretty good understanding of how negative is this right now? How bad has this gotten? How fast has it gotten that bad? And sort of where we are in the assessment and treatment of this patient having a stroke. So we're going to talk about some things that can mimic our patients who are having a stroke. And really, unless we can 100% identify that it is not a stroke, we're better off calling in our stroke alert to the hospital so that they will have the radiology people on standby, ready to come and take images. They will have treatments already started to be worked out and figured out for this patient. Because when we talk about heart attack, we say time is muscle. When we talk about stroke, time is brain tissue. So the longer we allow this stroke to progress and the longer it takes for definitive care and treatment and reversal of all these problems to start, the more negative side effects are going to just remain with this patient. Lots of things can cause bleeding in the brain. High blood pressure could be one of them. If we have a patient who's got signs and symptoms of a stroke with blood pressure that is continuing to trend upward and it's increasing and it's getting really high, that's something we want to watch out for. Because a lot like with the rest of our vital signs, when we talk about our shock patient and we're trending their vital signs, we expect the heart rate to go up. We expect the respiratory rate to go up. We expect the blood pressure to stay sort of initially the same and then go down a little. But the heart rate and the respiratory rate are going to continue to climb a little until they get to a maximum point where they can't go any faster. And even though they're going really, really fast, they're not doing any good because they're not pumping enough blood and they're not oxygenating enough blood. So that increased heart rate and that increased respiratory rate starts to trend downwards towards zero. Our patient who's got a significant brain bleed going on, we will trend an increase in their blood pressure because the brain is being squeezed. We have an increase in intracranial pressure, which we're seeing as an increased blood pressure. But then when my patient's blood pressure turns the corner and starts to go back down, did your patient get better?
No.
Yeah. When we see those weird changes, right? When we see weird changes in shock, or when we see strange changes with my patient who I think is having a stroke, if their blood pressure has been going up, we expect that it's probably going to continue to go up. But what goes up must come down. And the worse off your patient gets, we'll start to see things turn around and trend in the opposite direction. And that is really a pretty significant finding of my patient's condition has just worsened while I'm sitting next to them. So we have hypoglycemia, we have a post-ictal state, and we have subdural and epidural bleeding that we say can mimic a stroke. First thing we're going to talk about is seizure, and that will lead us to post-ictal state. Hypoglycemia we'll talk about a whole awful lot in just a little bit. Seizures are really sort of loss of neurological function. We see chaotic brain activity. The brain is not sending out its messages the way that they're supposed to. And when those messages get chaotic, it gets down to the end of the neurological system, and those nerve fibers will cause the muscles now to respond to that crazy neurological input from the brain. So 2 to 3 million people in the United States have been diagnosed with epilepsy. And those abnormal discharges from large area of the brain, generally across the hemispheres, so it'll be on both sides, we will generally see a rapid loss of consciousness. First thing we see a lot of the times is we'll see a patient stiffen up like a board and make this grunting sound, because that chaotic electrical activity depolarizes and contracts all their muscles, forces their diaphragm up, contracts their rib cage, and they let this grunting sound out because they are having this wild muscle contraction throughout their entire body. And then the next thing that happens is gravity helps them to the floor, not generally in a nice controlled fashion, because their brain is not really communicating well with the rest of them. And when they hit the ground, we will see that twitching that everybody thinks of when they think of their stereotypical seizure. This is a tonic-clonic seizure is what this is called. When the patient stiffens up like that, goes down, and then begins to sort of kibby on the floor. These can last for several minutes. And if the brain really isn't controlling things effectively during this time, what's something that's not happening for your patient?
Breathing.
And they're not breathing.
Yeah, they're not breathing. So your patient who is having this chaos being sent off by their brain down to their muscles is not breathing. They're not ventilating. They're not moving any gas because the muscles aren't functioning well enough, because the brain is telling them to do all these wild and crazy things, and all the muscles can do is what the brain tells it. So we are on the lookout for things like hypoxia when my patient wakes up from a seizure. All that chaotic muscle activity blows through sugar because those muscles are constantly contracting and relaxing, contracting and relaxing. So every time they do that, I need more sugar, got to create more energy, got to contract some more, need more sugar, got to create more energy, got to contract some more. And they just pour through the amount of available sugar in their body. Another reason I advocate for you guys to check a blood sugar on any single patient that is altered in any form or fashion, because your seizure patient who's not waking up, or not waking up really as quickly as you would like them to,
It just uses all that glucose.
Yeah, they've used all their glucose and they might need some. They could be actually suffering from hypoglycemia. Not all seizures are that big, twitchy, tonic-clonic kind, though. The book goes into great detail about the different kinds of seizures there are. First one we'll talk about here is an absent seizure. This is one that doesn't really involve any change in motor function. The patient will just sort of be staring off into space. You can talk to them. They don't respond to you. They don't look at you. They are just sort of lost on their own. Generally, the patient comes out of this pretty quickly. Since we don't see any real changes in motor activity, this patient is still generally going to be breathing, but they do sort of wake up confused and a little altered. That period of my patient slowly regaining their normal level of consciousness, their normal mental status, is what we call the postictal phase. Postictal is just your patient who had a seizure, whether it's tonic-clonic, whether it's an absent seizure, whether it is a focal seizure. It's that period where they start waking up. Our partial or focal seizure can be simple or complex. Generally, our simple focal seizure, or simple partial seizure, we'll see numbness and twitching maybe on one side of the body, maybe a little bit of paralysis, on one side or in one particular body part. Our complex seizure, partial seizure, we will have more of the body affected. We will have more of an alteration to our patient's mental status. And it's just because it is more of the brain and a more important portion of the brain, the temporal lobe, that is sending off these messages. The alteration for our complex seizure patient can really be significant. They can have hallucinations, uncontrolled fear. They can really sort of look like they are coming apart at the seams a little bit, but it's normally self-limiting. The brain generally does eventually gather itself together and start doing the right things, as opposed to just continuing to send off all of these crazy messages. Sooner rather than later, our patient enters that postictal phase and begins to wake up and begins to sort of get back about their normal function. It is very, very common for a patient who's having a pretty significant seizure to lose control of their bladder and their bowels, because the brain is not limiting where it's sending all these nutty messages off to. So it's not really controlling the normal functions of living either. So our patient will, a lot of the times, lose control. Patients before their seizure will sometimes have an aura. Now, it's not like, you went to, you called up Miss Cleo or anything like that, not that kind of aura. They will see sort of a haze in front of them and like almost like a ring around things. That's why a lot of the times seizure patients, especially experienced seizure patients, don't fall down and get hurt, because when they know the things that tell them that they're having a seizure, like changes in their sense of smell, changes to their vision, they see this aura, they sit down so that they don't fall down. Our generalized seizure, that tonic-clonic thing that we think about, is sudden loss of consciousness, chaotic movement, chaotic muscle tone, chaotic muscle spasming, and apnea. Apnea means they are not breathing. Most seizures are pretty self-limiting. They last about 3 to 5 minutes, and they're followed by that postictal stage. Our patient starts to wake up, our patient starts to get a little better, and things move along swimmingly. Status epilepticus is when that doesn't happen. Status epilepticus is when a patient will continue to seize and have either 3 seizures in a row without any real period of wakefulness, or 1 continuous seizure that may last for 30 minutes. And if a patient is seizing for 30 minutes, nobody's holding their breath that long. So they're going to have some pretty significant issues, whereas their brain has been hypoxic for the last half an hour. Status epilepticus is a big, big emergency. Status epilepticus is a truly sick patient. Paramedics carry meds that they can give IV to at least break this patient's seizure, so that they're at least no longer seizing, so that they can start breathing again. Our main treatment for a patient who is having a seizure is going to be keep them safe. Don't allow them to seize downstairs, like seize and fall again. Don't allow them to just continue to shake on the floor and knock things over on top of them. Most of the time, these seizures will go away. Most of the time, the seizures are really pretty well finished by the time we get there. What do you think we see with our seizure patients more often than not? which part of it do you think we actually get to lay eyes on?
Them coming out of it and coming to.
Yeah, we get to see that postictal stage. So how do you think we get our information about what this seizure looked like and about how this seizure happened?
Friends and family.
Standards.
Friends and family. When we're asking our OPQRST and we're trying to maintain this seizure patient and do what we can to make them better, we ask the family. We ask people that were with them, people that have seen them have a seizure before. Was this different than anything else, or was this sort of the same? They'll know. Our patient, as they begin to wake up, we can start asking them some of the mental status questions, because now I'm reassessing and I'm trending my patient's condition. I'm finding out, how do you feel? Do you feel like do you see any disturbances to your vision? Do you see anything that points you and leads you towards maybe you're going to have another seizure? We start to, get down to brass tacks and figure out, is my patient getting better? Is this truly them in the postictal stage and they're starting to wake up? Or was their seizure so negative for them and lasted for so long that now I need to work at correcting this hypoxia or hypoglycemia? And what are some things we could do to fix those two problems? Come on, fellas, I'll wait. What do you think we can do to fix hypoxia or hypoglycemia with a patient who just had a seizure?
We're gonna give them oxygen, non-breathable mass, 15 liters per minute, and maybe give them some medicine for their blood sugar.
Some glucose.
We can give them some oxygen, 15 liters per minute, non-rebreather mask, because even 3 to 5 minutes of not breathing when they were having a seizure is significant. If they need it, we can give them some sugar to get them out of that hypoglycemia, as long as they can protect their own airway. And I have verified that I have a blood sugar of below how much?
Below 60.
70.
70. Anything 70 or below and symptomatic, we can treat. Good, 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 good. So the last thing we're going to talk about right here is a syncopal episode. Syncope is just an unknown loss of consciousness. Syncope can have as many different causes as there are days in the year. This is just a patient who, for one reason or another, had an unexplained loss of consciousness. It could be from hypotension, it could be shock, it could be a cardiac dysrhythmia, it could be a respiratory problem. Generally speaking, syncope doesn't always boil itself back to a true neurological issue, because the loss of consciousness is normally about that long. A syncopal patient, a true syncopal patient, will be walking 1 minute, minding their own business, and the next minute they are waking up on the floor about 12 seconds later, trying to figure out what in the hell just happened and how did I get here? Our syncopal patient is going to be somebody we will treat associated injuries from their fall or associated signs and symptoms. If you see any hypoxia, you treat hypoxia. If you see any other issues, you treat those other issues. Check a blood sugar because they were altered. And we'll start getting down to the where's, why's, and what for's and treating that. Because at the end of the day, even when they get to the emergency room, and the emergency room does all sorts of fancy things to try and figure out their unwitnessed syncopal episode, they may find absolutely nothing. How was that, guys? Pretty straightforward?
Yep.
Good.
Yes, sir.
Good. All right, let's take 10 minutes, and when we come back, we'll talk about endocrine emergencies. Let's see, what time is it? I have 9:56. Why don't we call it, let's say 10 after 10. We'll take 14 minutes. On your mark, get set, go. All right, everybody, we're back. Real quick, before I start the lecture here on endocrine and we move on to behavioral and psych, I'm just gonna close the meeting out and then open it right back up so that way I can put this recording on the right class in Tavuti so you guys will know where to find it. So I'm gonna shut this down and I'll open it right back up. All you gotta do is log back in, same as yesterday, okay?
Yeah, sounds good.
All
Okay.
right.